Hey everybody, the procedure I'll be covering today is triple arthrodesis of the ankle. The definition for that is a fusion of the bones of the ankle. Why would a patient need this? This is a procedure that helps fuse the bones and eventually relieve pain they may be experiencing, provide stability, and also help to arrest joint-destroying disease processes. Provided a quick picture of the ankle here just to get a quick idea of what the anatomy and physiology may look like. As you can see, the tibia and fibula come down to meet the foot. The larger heel bone, the calcaneus, is involved, and we will explore the anatomy and physiology a little later in this presentation. But that's a quick shot of it. So let's break this down journal style. We're all used to doing journals. I thought this might be the most familiar way and most helpful way for us to learn the procedure. So what's the anesthesia? Is general anesthesia. Patient will be under for a couple hours for this procedure. How will the patient be positioned? They will be positioned in the supine position, and then depending on surgeon preference, sometimes surgeons like to have the leg flat on the bed. Others like to put a piece of Rapco band underneath the ankle, kind of behind the Achilles tendon, to kind of give it a little lift. And of course, all the bony prominences will be padded, the arms will be out, and a safety strap will be placed 2 inches above the knee of the non-affected leg. How will the skin be prepped? Most often you will see ChloraPrep, but I did notice at Maine when I was there recently that they are trying to switch a lot of their ortho to DuraPrep. But either way, you will still start at the ankle, moving outward. This will include the toes, even down in between the toes. Then you will move circumferentially up the leg to include the knee. The other thing that I've been seeing is a lot of doctors, if they are doing this on a pediatric patient, they tend to first use alcohol all over their leg, toes, ankle, everywhere, and then move to the DuraPrep actually. But either way, then you'll have a 3-minute wait. At this point, somebody will need to hold the leg up off of the table. This can get a little tiring. Usually the circulator, you may need to help. Sometimes the surgeons will do it, or if they have an assistant. How will the patient be draped? Under the affected leg, we have been laying half sheets on the bed. The foot will then be grasped and a stocking net will be placed over it and brought up to the top of the thigh. Usually 2 people are doing this. A U-drape will then be placed around the lower thigh. And lastly, the foot and leg will be passed through a fenestrated drape, such as a transverse or a laparotomy drape. The arms of the patient will be out, and usually you'll need to put half sheets over those as well, since you'll be moving closely to those at times. Sometimes you may also need to cover equipment toward anesthesia that kind of sticks out to the side. So there'll be more half sheets used in ortho, is what I noticed. And also you'll need to drape the C-arm. All right, before we dig in, I was thinking we could take a 30-second break and everyone could go wash their hands. Okay, so for the instruments, supplies, and equipment. For the instruments, it'll be the basic orthopedic procedures tray. You may also have a minor instrument set to go along with it. You will see a power drill. More often than not, I have noticed that they use a battery-operated one, so you'll need to click in the battery at the bottom of the drill. I haven't seen one that has a cord yet, but that is also a possibility. You also have a set of drill bits. You may have screwdrivers to go with those in case they want to manually manipulate it. Osteotomes, of course, to be able to chisel away at some of the bone. That'll come in an entire set of different sizes. The surgeon will ask for different sizes throughout the procedure. You'll have curettes for scraping, gouges. Then they'll also have Steinmann pins or Kirschner wires. This is to help drill in and get the bones in position to fuse them into the right position. These wires are drilled in and they kind of hold the bone exactly where the surgeon wants them to be. leading up to putting in a screw or staple or nail. The other things that you might see as a fixation device, like the whole set of screws, staples, this is dependent on what the surgeon prefers to use, but you'll have usually a whole set of screws. Vertebral spreader, and depending on what's going on with the patient, you may see a pulse lavage suction irrigator as well. You'll also see a major pack. You'll see S-mark. A tourniquet will need to be used for this procedure. There'll be some Weebrel, tube stocking net, definitely a basin set, your grounding pad, because there'll be the bovie used. Each patient will get a sequential compression device put on their legs. You will have sutures, of course, and at the end of this one, they will be in a long leg cast, so you'll have casting material. For equipment, you're going to have your usual OR bed, excuse me, the ESU. For ortho, you may have a long back table. You may also have a double back table where there are 2 levels to it. When I've seen those, I usually have seen the preceptors put a lot of the softs on the bottom, and maybe the screw set and the osteotome set and the K-wire set, and then they'll usually move all of their long instrument sets to the top table. It takes 2 people to set up the double table and to drape it, so you may see either one of those being used. You're going to have your Mayo stand, a prep stand, some standing stools, kick bucket, of course, suction, and then you also have a C-arm. Then you'll need a lead apron. Eventually at the end, you'll need a cast cart, and then you need the tourniquet and insufflator. Some people also have a leg holder that they use. I haven't seen one of those myself. Anatomy and physiology, pathophysiology. So the focus of triple arthrodesis is to fuse together the talocalcaneal, the talonavicular, and the calcaneocuboid bone articulations. As you can see that in the picture on the right, you can see where these are all located in the ankle and foot area. So fusing these together helps patients that have pain, instability when they're walking. They may have arthritis and various diseases. They could have also been born with a deformity. And so fusing these together really helps them moving forward. This can be classified as intra-articular, can be classified as extra-articular, could be a combination. This is also able to be done arthroscopically. Some diagnostic interventions they might have leading up to the surgery. They may go through all sorts of testing. Most people will have at least had x-rays and MRI testing. This also depends on why the patient needs this in the first place. Do they have arthritis? Were they born with a deformity? Are they having instability walking? And so they may have various types of testing depending on what led them there. So, for instance, they have arthritis. They may also go through an arthritis panel. You may see a patient that has already had a bone density test or a bone biopsy, joint fluid analysis, and other imaging studies before they ever get to the point of having the procedure done. So let's dig into the procedure. So the prep is dry, the tourniquet is all inflated. As we know, for the lower extremity, the tourniquet cannot be on there for more than 90 minutes, so that is a consideration. And they'll usually start with an x-ray, an A&P, anterior and posterior view, kind of straight up from the ceiling to the floor, kind of get what's going on in there, and the surgeon will be able to move on from there. The incision will be made from the dorsal prominence of the lateral aspect of the foot to the mid portion of the calcaneus. I personally have seen them usually make this with the number 15 blade. A blade can also be used during the initial x-ray to kind of poke in and see where things are, and that kind of lets them know where to make that incision for that patient. At this point, the tendons are retracted, and I've seen them use Sen retractors mostly. I've also taken my Army Navies, and you'll see later on my back table, take my Army Navies out of the instrument set because they sometimes ask for those throughout the procedure. But mostly your Sen retractors I would have on your Mayo. Exposing the floor of the sinus tarsi. The periosteum and the calcaneus is exposed. They'll be using the freer on the periosteum and the baby Holman as well, but the freer really to scrape that off and get to the bone. The calcaneal cuboid joint capsule is then incised, and the articular surfaces are excised. Again, using the freer, they may ask for the osteotomes at this point, maybe going through different sizes. You'll also want to hand them the mallet right away with the osteotome so they can use it. The bone fragments will be saved, so be there to grab those with a Raytech, and you can save them in a medicine cup or something in the back on your table. The talonavicular joint capsule is incised, and the head of the talus will then be excised. The proximal articular surface of the navicular is removed, and the subtalar joint is incised, and the articular surface is removed with the sustanaculum tali and anterior facet of the talus. At this point, all the bony surfaces will be trimmed and smooth so that when they do fuse them together, they're not all jagged, and that will help them have contact to also minimize pain later for the patient. Sometimes a medial incision may also be required if they want to get to it from the other side. Otherwise, you are starting laterally. At this point, bone chips may be packed into the defect, and soft tissues are sutured to fill the sinus tarsi and get rid of dead space. So again, we're fusing those three bones together. We want to get rid of the space. Here's where your Kircher wires, pins, and screws and staples are going to be used. Like I said, they'll use those wires to drill in. They will constantly be using x-rays throughout this. So one thing that I would say as they ask for a lateral, it means that the C-arm is going to come back up through toward the surgeon and yourself and your Mayo stand. And so you'll want to be there to cover the bottom of that C-arm as it comes around, because initially you have just covered the top of the C-arm. But they will use that a lot to just keep seeing where their K-wires are, where the bones are, and getting them into position. A long leg cast is carefully applied near the end, and this makes sure that the foot is molded into the correct shape. This is after your K-wires have stabilized it, they have put in the screw or the staple or whatever their preference is, and it's all finished. It's in the right exact position. Sometimes a couple weeks later, they may need to come back in to remanipulate the foot, and this would be done under anesthesia, but this could also occur. So your counts would occur before the start of the procedure, of course, and in ortho, you really just only need to count your softs. So your blades, your hypo, your sutures, your laps, or at this point, I guess, for this procedure, it would be Raytex. And you would count again for your second count after they're closing the fascia, or when they're closing the fascia. And then your third count would occur when you're closing the skin. Again, you don't need to count all of your instruments for these procedures. Catheters and drains would not be utilized in a triple arthrodesis. As far as specimens, you would not be sending anything to pathology, although I had a case last week where a young man had broken his femur because he had a cyst that hadn't been taken care of for 2 years. And so we sent some of the intramedullary cystic stuff that came out of the fever down to pathology to be tested. So I guess if your patient has, a tumor, a mass, a cyst or something, otherwise you're probably not sending a specimen at all. Here's a picture of the back table setup. Like I said, I kind of set this one up as if you only had one table. If you had the double table, you would move your minor instrument set, your orthopedic tray, to the top. You would probably keep your screws and K-wires down on the bottom. But for this, I just did one long back table. You can keep all of your instruments in the tray, just set them on there. You would probably have your softs on the right, depending on what side of the room you're in. And you're going to make a safety zone. You'll also have, your typical needle pad suture in there. And then you can do a little roll towel and bring out your stringer or the things you'll use the most. And roll that up there. You want your pack of Raytex there, blue towels, and a big old basin in the back of NaCl, and your pitcher in there. Some things I said before I pulled out was my Army Navy. I feel like they kind of asked for that. You can hang your pickups on these trays in the front. I usually separate mine, teeth on one side and no teeth on the other. Then you also have your whole set of screws and K-wires. And each of the K-wires have specific sizes. So they have little holes in the K-wire set that when they ask for a size, you can push it down in that hole and be sure that they really are the size that they say they are in the tray. So you want to check every single K-wire that you're about to use. There's a different adapter for the drill depending on if you're going to use a drill bit versus K-wire. So I would have that second adapter on my back table as well. Mayo stand, my experience is the surgeon stands there. Probably they have an assistant with them, whether it's a resident or a first assist or a PA. And I have stood behind them with my Mayo stand. I have pulled up my back table kind of behind me, but I pretty much have worked all ortho cases off of my Mayo, standing right behind them. And so my recommendation would be to put up the things you're using right then on your Mayo and not to try to work off your very hectic back table. So you're going to want your knife, both sizes. They usually use 15 and possibly an 11, but you might just have two 15 blades up there to keep them sharp. Your safety zone, your two Raytex, of course, your Sen retractors. Then you're going to have your drill with the battery attached at the bottom. Always two curved stats, a couple Alice and a tonsil, and two Addison with teeth. You'll be able to hand them one K-wire, but they'll need more, and so you can put some more up on your Mayo stand, of course, after you check their sizes. The other two things that I use a lot in ortho, I found, is your Freer and your Homan. They just constantly ask for those two. Definitely have a Freer, definitely have a Homan. Usually a baby Homan, sometimes a big one, but usually a baby Homan on your Mayo. Special considerations for the surg tech, you'll need to put on a lead apron before you get gowned and gloved. You also want to use the thyroid shield as well. There'll be a lot of x-rays taken for this procedure. And a good reminder, time, distance, and shielding are your best friend. You will most likely have a very large table. We covered this kind of already. Maybe a double table for instruments, trays, and supplies. For most ortho, we utilize the Mayo, as I just mentioned, and kind of just reach back to that back table to grab specific screws they might want, or your K-wires, or all of a sudden they ask for a certain thing on your stringer that you don't have up there. Then you can reach back for that, but for the most part, you're going to work off your Mayo. Again, double check your K-wires. And then any item that's going to stay in that patient, like a screw, you'll need to let the circulator know the item number, who made it, the expiration date, and this all needs to be charted. So be sure that you write down the size of the screw and everything about that. You can usually do that on your little card that your string was on from your gown. Previous x-rays will oftentimes be in the room. There'll be a C-arm in the room and also a person from radiology, so the room can be a little crowded and you'll want to protect your sterile field. Lastly, be sure to cover the C-arm bottom as it comes around like we talked about earlier. So as soon as you hear the word lateral, that means the bottom of that C-arm is coming back up around to your side, the surgeon's side, towards your Mayo. You'll need to pull your Mayo back, quickly cover that. Usually there's a big plastic sheet on the side of the patient that you'll just kind of wrap around. You'll protect your surgeon, you'll protect your sterile field as soon as you hear the word lateral. Special considerations for the patient, in addition to normal ones, the patient's leg or foot may need to be manipulated a lot, so special care taken throughout the procedure for that. The tourniquet should not be left in place for more than 90 minutes. And, if you have a younger patient or anything, or maybe even some of the older ones, they get to usually pick out the color cast they want. So don't forget to look at their chart for that at the end when you're helping with casting and make sure that's what they would like. Prognosis, most patients have relief through triple arthrodesis. Again, depending on the reason that they're there, it could vary on what their prognosis ends up being. Physical therapy will definitely need to be utilized post-operatively, and some patients may need additional surgeries to reach the maximum comfort and mobility, especially if you have a deformity or something. Also, if your patient is younger, throughout their life, they may need this to be changed a little bit as their bones grow. Complications, same as usual, anesthesia, surgical site infections, deep vein thrombosis, also always a consideration during surgery and after. As far as wound management, the first few weeks there'll be a long leg cast on there. So, they cannot get that wet, of course. The incision site would be covered from that cast. The dressing that they would use would be the steri strips, followed by Telfa, followed by Tegaderm. This would be all under the cast. They would also change this out in a few weeks when they get the cast off. And the wound classification would be class 1 clean. I made you a little Mayo Stand word find if you'd like to take about 30 seconds to try to find some of the items that you would see on your mayo. You can do that now. Okay, time's up. So in class, I was looking to give you all a couple minutes to be able to do this word find and take it home, but switching it all over to online, add 2 minutes, I guess, print it out, whatever you want to do. But you can see that you would have, again, the Raytech, your knife, the drill. You would want your sends up there, the Homan, the Freer, your curve stats, Alice, your tonsil, and your Addison with teeth up there on your mayo. So these are some of the main items. And that is it. So I really appreciate y'all tuning into it. Sorry we couldn't do this in person. And if you have any questions, you're more than welcome to email me. I'm not an expert, but I'd be happy to help you out in all of those. All right, have a great day, everybody.